what I'll do today is give a little travelogue story about my very fun time volunteering as a neurosurgeon in Nepal and also in the Maldives Islands. And what I'll do is give a little history and then a lot of pictures and show some cases. I started my volunteer time in Nepal thanks to the Foundation for International Education in Neurosurgery, abbreviated FIENS, that at the time Merlin Bagan was head of, and he's past AANS president. I think many of you know him. He placed me at the place in Kathmandu where he built up the neurosurgery program in the 1990s. I told him that because I love Nepal as a climber and trekker, I wanted to go back and give back to the people. So he said, great, I'll introduce you to the neurosurgeons in Kathmandu at the Tribhuvan University Teaching Hospital, and you can volunteer there. Nepal has always been a favorite place of mine. I've been there more than 25 times now, and initially as a trekker and climber, and then now as a neurosurgeon and educator. For those of you in the audience, Nepal is a country south of the Himalayas with a very low GDP, but the world's highest, tallest mountains. And it's also the birthplace of Buddha. Life expectancy is now pretty good. When I first started going there, it was in the 30s. So now it's 70, but it's still very poor, resource constrained. And they do neurosurgery there to a very high level since the 1990s. And I'll give a little history of what's gone on there since I first started going there in the 70s when there was no neurosurgery. I was there just as a trekker and climber and saw and asked and found out no neurosurgery went on there. So when I started looking into it, I learned the history. The history is pretty interesting. Besides Merlin Bagan, there are several other illustrious neurosurgeons that started working in Nepal around the same time, and including Henry Marsh, who has written a number of books about neurosurgery. Also, Dr. Dev Kota, who is one of Nepal's first neurosurgeons. He reminded me that he met David Newell, another University of Washington neurosurgery name in England. And Dave asked Henry to take a mole off his arm. And that was a neurosurgical procedure, according to Dr. Dev Kota. It was like a 2-millimeter mole. So he said he did the first neurosurgical procedure on another neurosurgeon. Kind of a joke, but that's Henry Marsh's humor. So Dr. Bagan really put it on the map with serious neurosurgical procedures, not moles off people's arms. And he started doing laminectomies. He did a TSA. He did spinal instrumentation. And when he was placing me in the hospital, he said, Rich, when you do spinal instrumentation, the way you do it is you send the family of the patient to the market and tell them what size metal rod to buy at a kitchen shop. And then they bring it to your hospital and you bend it and cut it and have it sterilized, and then you wire it in place just like a Lukey rod. That's how you'll do your lumbar fusions. And that at first obviously put me off a little bit because I thought, well, at least I can do screws and rods and cages appropriate to the era that we're in. But there was nothing like that at the time that I started working there. So one of my first missions was to try to get donations from medical device companies for more modern spinal instrumentation. And indeed, if you fast forward to last year, when I was there in November, we were able to bring over $1 million worth of implants donated by a lot of the medical device companies that we all work with and know and trust, so that now they have a steady supply of really good quality implants that are provided for free to the patients in Nepal who really can't afford to buy implants in most cases. Present neurosurgery, as you can see in this list here, is really starting to move rapidly into the modern era. There's endoscopy, there's stereotactic procedures, there's up-to-date CTs and MRIs. This year they're getting a stealth station. They have first-class microscopes. So things are moving along. But you'll see some of the cases that we do there when I go there that still show that they're first-class neurosurgeons, but they appreciate the extra education and training and in modern day techniques. Particularly what I'm focusing on is minimally invasive spine surgery and some complex spine surgery. And they have a huge number of cases that need both of those types of interventions. They're a very busy place. And the two major professors, I think some of you may recognize the gentleman on the right, Dr. Sharma, Mohan Sharma, spent time.
Time with us. Yeah.
He's very constantly reminding me of his very memorable and fondness for time in Seattle. Loved it. And Sushil Shilpakar, who is Merwin Bagan's first trained neurosurgeon, didn't come to Seattle, but did go to Arizona and Emory. So both of these gentlemen are very well trained and just great to work with when I go over there. This is a hallway at the teaching hospital. This is us in surgery, and the Maldives connection. I thought I'd start by showing the gentleman next to me, Dr. Ali Niyaf, was the chief resident 10 years ago at the teaching hospital in Kathmandu, but he's from the Maldives. And I'm going to give a little segue into the Maldives here, and then we'll revisit it in a minute. But Maldives never had a neurosurgeon until Ali was brought back to the Maldives, which is an island country south of India. At the time he started there about 10 years ago, there was 400,000 people that all, if they needed neurosurgery, had to leave the islands. But now that he's there, he's built up neurosurgery there, and he invites me there every year to give talks and do some first type of surgery, like a first cervical arthroplasty or a first stealth guided spine surgery or something every year. So I've been doing that in addition to going to Nepal. This is a case that we did in Nepal when I first went there. This is a young guy who was an injured worker at a farm, 9 days walk, literally walk out of Kathmandu, who had a fractured dislocation of the cervical spine. This is a typical sort of case where this sort of injury occurs. They go to their local doctor in the village, and the doctor says, you'll be okay, just wear a collar. And the patient obviously has progressive pain, numbness, tingling, starts to have weakness, myelopathy, and eventually gets referred into the Tribhuvan University Teaching Hospital, where I do the volunteer work. And we see him literally months after the injury, and did a 360-degree surgery on him to decompress and fuse him. And he had come in with every rupee, which is equivalent to dollar, that he had, knowing that if he needed surgery, he gets the bed for about $1 a day. But if he needed any implants for his spine surgery, he'd have to pay for it out of his pocket. And his entire life's earnings was brought in a little bag. And when he heard that I had brought cages and plates and screws that he needed for his surgery and was donating them, he literally, started crying and thanking everybody for the fact that he was able to get this surgery for free, basically, other than the $1 a day. And he did great. So this is a couple slides teaching different types of surgeries. And then I'll show some travelogue pictures here so that people get an idea that when we work and you walk out the door, these are the types of sights you see. So when I bring people with me, we do work all day long, but the sightseeing, particularly for people who've never been to Nepal, really, really incredible. Then after I started volunteering there, I invited Sushil and Merwin to come to my spine meeting over near Mazama in Winthrop at Sun Mountain Lodge, and we put on a seminar about volunteerism in neurosurgery and tried to encourage other neurosurgeons to join us. And sure enough, I've been lucky to have another neurosurgeon that you all know, Dr. Faroki from Virginia Mason, joined me in the last 3-4 years every year, and a neurosurgeon from Arizona, Dr. Chua, Rick Chua, no connection to University of Washington, a fabulous neurosurgeon. Then several other neurosurgeons. Jay Shri wants to go with us this year. So strong UW connection continues. The meetings that they have in Nepal are excellent. We always enjoy going to their meetings and learning from them as much as we try to teach them. Here's some pictures from the wards. There's Dr. Devkota and Dr. Marsh. And then one other thing that can be done real easily, if you're in Kathmandu, you can fly over to Bhutan or Sikkim or other parts of the Himalayas in an hour, have the most amazing flights, do this sort of thing in a weekend, and go on a trek in Bhutan or do a trek in Nepal if you want to, just hopping on a short flight to a remote location. And it's a fabulous experience to be able to see and do something like this, going up to the Tiger's Nest Monastery on a weekend trip to Bhutan, and then coming back to Kathmandu and continue working. So in keeping with my promise to talk about the Maldives, this is a country that's not resource constrained like Nepal, that has a lot of ability to go right to the first class medical equipment and care. And it's a country that's very unique and very different from Nepal. Nepal is the country with the highest mean altitude in the world, and the Maldives is the lowest, basically. So you're basically at sea level, and everybody says that it could disappear, you know, with either a tsunami or global warming raising the ocean levels. 2,000 islands are literally a foot and a half above sea level. It's a beautiful place, extremely different from Nepal. They're doing all kinds of neurosurgery, but Ali, just as a startup, was only able to get credibility to do carpal tunnels for the first couple of years, and then he's credited my bringing new techniques for gaining credibility amongst the people of the Maldives, who really still left the islands even though he was practicing. And then having the new surgeries being brought to the islands and broadcasting them to thousands of people with live broadcast added credibility to his program. So he's done over 1,000 surgeries now, including aneurysms and tumors and all kinds of spine surgery. And this has been great fun. The first time I went, it was bare bones, minimal surgery. We did this meeting. We had 5 speakers, 30 attendees, but all these live broadcasts with over 65,000 viewers really helped to get more attention to what he was trying to build up there. And this case really brought it home and helped his program. He wanted me to do a cervical arthroplasty, and I kept asking him, well, who's the patient? What are we going to do? he said, don't worry, I'll find the right patient for you. So I landed in the Maldives. I said, Ali, who's the patient we're going to do? I need to see the films. I want to know the history. I want to meet the patient. So he said, well, actually, it's my anesthesiologist who has a horrible cervical disc syndrome, can't operate, can't intubate, can't operate with me. So I can't operate until you fix her neck. And she doesn't want to leave the Maldives for an arthroplasty elsewhere. And she doesn't want to have a fusion that Ali himself could do. So she's been waiting for you to do an arthroplasty. So I brought the Moby C, and we fixed her. And as we were going into the operating room, she said, Dr. Wohns, I'm not afraid of the surgery at all. I'm just afraid of the anesthesia. So I thought that was pretty humorous. But anyway, she did great, and she's back to working with Ali. And this case was a very high profile case, so really helped Ali's program. And back to Nepal, sometimes I do the trips back to back. So some of the meetings are Spine Week in Nepal, with Ali's meeting promoting new neurosurgical techniques in the Maldives. But I've learned that it's probably best to separate these two because it's pretty intense and there's a lot of flying. So nowadays, doing one trip to Nepal, one trip to the Maldives. And this is some of the neurosurgeons in Nepal that I've gotten to be good friends with. And we meet every year, do surgeries together, and do lectures. And some pictures from the OR again, doing typical cases. Usually they have 3 anesthesiologists, maybe 4 or 5 neurosurgeons, and either myself or Farouk or Rick kind of leading the case if it's a new type of technology. Here's a typical case we're doing more of lately. We've been showing them initially mini open spondylolisthesis reduction and fusion, decompression and fusion with pedicle screws, cages, etc. And then in the last 2 years, we've been pushing the education for minimally invasive. So we've switched over from the mini open approach to minimally invasive. One of the years I did a ProDisc C, and that was the first arthroplasty in Nepal. Again, you walk outside the hospital, and it's a photographer's delight seeing pictures of people, the color. So it's a nonstop experience in surgery, outside of surgery. Great social events, great meetings, always fun. This is probably the most colorful holiday in the world in Nepal. It's called Holi. They throw powdered paint on each other, and if you go outside from surgery and don't remember that it's Holi, you come back totally covered in colored paint, and quick shower and then back to surgery. Our group from 5 years ago had quite a number of people that I brought over from the States. We taught neuromonitoring, anterior approaches to the lumbar spine, pain management, a whole bunch of other things. And the group every year is growing. Last November, I took 12 people with me, including a Mayo neurosurgeon and a Stanford professor of orthopedic spine surgery, Rick Chua, and Farouk, myself, and a bunch of people from Medtronic and other companies. The one benefit, the side benefit, as I mentioned, is like a weekend trip to the mountains. 1 year, I was able to get permission and took my youngest son on a trip to Mustang, which is an incredible experience. It's kind of the lost kingdom. It's a Tibetan kingdom in Nepal. We were the only trekkers in the region and spent 6 days trekking from south to north, and had a fabulous experience seeing very, very unusual Tibetan scenery and gorgeous villages that there were no other Westerners there at the time. And then back to Kathmandu, literally a helicopter ride, 2 hours, and you're back to work. So again, promoting intense neurosurgery, but also intense cultural and outdoor experiences is part of this volunteer program. And most of the people that come with me do a short trek or at least some sightseeing. So they really have good experiences, not only at Tribhuvan University Teaching Hospital, but in places like this where they can see ancient monasteries, meet lamas and Buddhist priests, hear stories from climbers who've been to Everest, etc. So continuing on, as I mentioned, the Maldives started out with 5 speakers at their first meeting, and then a year later, 30 speakers. First time it was 5 countries represented from Southeast Asia, and then 7 countries with 150 attendees. So everything's growing every time I go, and it's really fun to be part of all this that really didn't exist before these volunteer trips started. The first lumbar arthroplasty I was privileged to be part of. Also, I taught this and did this surgery on a young soccer player, and he did really well. He was again somebody with severe discogenic back pain. You can see the black disc at 5'1", failed all forms of conservative treatment, couldn't play soccer, and we did the Pro Disc L. He did well, and then there was this little lady with Spondylolisthesis, black disc, horrible back pain, and this patient needed an anterior fusion. So these were the first anterior fusions in the Maldives. Both patients did very nicely, and the patients came back to see me the following year. They were followed by the local docs, and then came back to see me a year later and shook hands. This is the first SI joint fusion in the Maldives. Again, technology never done there before. This was the Pro Disc L patient that came back to see me for follow-up a year after, and he sent me a note, which I included here because even after 40 years in practice, one of the best things of doing neurosurgery is just getting a thank you note from somebody that you've helped. And I thought this thank you note was really touching. So I know everybody in the audience, particularly my professors and Rich Ellenbogen and everybody, gets thank you notes like this. And I'm sure we all feel the same way, that when people just send you a little note like this, it's pretty special. So moving forward, spine conferences, there's Dr. Faroki, Dr. Chua over next to Dr. Faroki. We give a lot of lectures. Sometimes we go there and we're giving a total of 20 lectures amongst the group of invited guest surgeons from the US. So we're not only busy in surgery all day long, but a lot of lectures. And one time I was kind of running out of neurosurgical topics to discuss. And I asked Dr. Sharma, the neurosurgeon who's now chairman, well, what else would you like me to talk about? And as you remember, he was at Harborview and the UW for a while, and he looked at me and said, Dr. Wohns, we need help with medical legal in Nepal. I said, what? And he said, yes, you may not know, but there's no due process for medical legal cases in Nepal. If we have an aggrieved patient or a family that's not happy with the outcome or some really adverse occurrence, they have no lawyer or court system or due process to provide them recourse in the setting like we would have in this country with a malpractice suit, at least to have their day in court to discuss whether the allegation has merit. And what they do in Nepal, Mohan told us, was they do ad hominem attacks by standing on the doctor's doorstep outside their home and waiting for the doctor to come out of their home, get the media there and throw rotten eggs and tomatoes at them and talk about how terrible these butchers are. And the media catches it. And this is their way of getting even with the doctors. So Mohan told me, you've got to help us get out of this situation. This is horrible. Everybody needs protection. Patients need protection. Doctors need protection. So now every time I go there, they have me give medical legal lectures. And I think this year I'll be bringing 2 lawyer friends of mine who are very interested in helping them set up better peer review systems, better credentialing, and work with local attorneys to try to develop some sort of process where patients can get legal help, doctors can have malpractice insurance, which doesn't exist. Anyway, I thought you might be interested in hearing that was one of the major requests for lectures after I ran out of neurosurgical topics. So here's the group. The residents, 2 a year. They do 3 years of neurosurgery after 3 years of general surgery. So they're fully trained general surgeons, and then they get 3 years of neurosurgery training, and then they take a job after that. Could be a faculty job, or it could be in a hospital where the government places them in a remote area to develop a neurosurgery program. When I first started going in Nepal, there, as I mentioned, there was hardly any neurosurgery going on, and then they built it up year by year. But in the early years when I was going, there was under 10 neurosurgeons. There's now 120 neurosurgeons in Nepal. So it's pretty amazingly fast growth of neurosurgery in a country of 30 million people that really needs about 300 neurosurgeons. So they're on the move. These are kind of cases where I learn as much as I teach on other cases. Like, this is not something we saw at Harborview or the University of Washington. This is a pot spine case. This was a case that came to us in clinic. A woman hadn't walked in 9 months, not only because of developing myelopathy, but severe pain, severe kyphotic deformity, cord compression, thoracic spine due to tuberculosis. And that's just not something, at least in Seattle, we see hardly at all. Maybe in other parts of the country, there's more cases of TB, but I learned a lot about how to take care of TB of the spine in Nepal. And this patient underwent a limited decompression infusion. We had no cell saver. The plan was, we initially planned anterior posterior decompression fusion with corpectomy and laminectomy and posterior fusion, but given the constraints of the hospital system and numerous other constraints which you can imagine, we did a posterior decompression and fusion, and she was able to walk for the first time. We got a really good result without doing any anterior work, and did everything posterior, and she did just fine with this. And we continue to follow her to make sure she doesn't need anything else, but she's a happy camper, and we're happy with the outcome. So during COVID, this is a busy slide, but the point is that during COVID, we stopped, the trips to Nepal were just not able to be conducted. Nobody was traveling, the country was locked off. So I instituted a Zoom monthly teaching session where we would have a speaker from the Western world and then 2 resident case presentations. And that would be done at a time, and this is always a difficult thing when we're doing telephone calls or Zoom meetings, because the time difference is 12 hours to Nepal. For me to fly there, by the way, is literally a 12-hour time zone difference. It's almost exactly halfway around the world. And when you get on an airplane, you all know, you can get there, but Zooming is actually more difficult because you have to pick a time that works for everybody. And so we figured it out. We do a Friday night Seattle time, which is early morning Saturday, which is their day off from the hospital. And we meet and we have the guest lecture followed by resident case presentations. And again, in keeping with the theme of me learning something quite often when I go there, the resident case presentations are amazing. And I just picked out one to show. If you look down here in 2021, June 25th, 26th, we had a presentation by somebody who was at the University of Washington, Dr. Feroz. He taught paper writing and publications, but the resident case presentation was a tiger maul, a tiger bite, injury to the cervical spine with quadriparesis, spinal cord injury, and how to manage that. And so they showed this case, again, a worker in the field who was attacked by a tiger, and the tiger bit into the neck, numerous puncture wounds to the dura, injuring the cord, CSF leaking out, and obviously the local hospital couldn't handle it. They shipped him in to the Tribhuvan University Teaching Hospital, and the resident went through the presentation on how they diagnosed and treated this case, who did improve after the dura was repaired and the cervical fractures were repaired. But the reason I'm showing this is that Sushil, the prior chairman, the first neurosurgeon, and said, Professor Wohns, how would you handle a tiger bite in your practice in Puget Sound region? And he was obviously setting me up. And I said, well, I have zero experience with tiger bites, but I asked questions. Well, what's the mouth flora of a tiger versus a dog? And we went over antibiotics and general principles of neurosurgery applied in terms of taking care of dural repair and cervical fractures. And so I was able to chat about that sort of thing. But then at the end, he said, well, Professor Wohns, how would you prevent this sort of injury? And that's why I included this picture with masks worn on the back of people's heads. You may have, in the audience, have seen a National Geo special on the honeybee hunters of Nepal, where they all wear these masks on the back of their heads because tigers do not bite faces. They attack people on the back of their body. So if you wear a mask on the back of your body, tigers don't bother you. So this is, again, something I learned. Sushil, kind of was setting me up for how do you prevent a tiger bite to the cervical spine? Well, now I know. You wear a mask on the back of your head. So anyway, take home message. This was Spine Week. We call our visit now Spine Week. We do 1 to 3 weeks of time in Nepal. In 2021, this was our schedule. We had a really nice schedule every other day in surgery, 2 to 3 cases, and then every other day lectures. Our summary of cases on the bottom there, you can see we started in the minimally invasive realm, and we still do some routine neurosurgical cases. Last time we went with Medtronic, they helped us out. This was the 2021 trip. We had a storage shed here near where I live, and we started amassing donations, and we were able to bring over 3 metric sets, hundreds of cages, plates, screws, etc. And the way we bring a lot of this equipment in was according to Merwin Bagan's teaching, never ship, always carry. So we never ship these things over because it gets locked up in customs. So one time we actually had a donated robot that Medtronic was going to let us use for a couple months, and we were going to teach robotic surgery over there. And that was totally successful until we realized that if we shipped it, it was going to be held up in customs until we paid 20% duty on a $1 million device, even for a 1 or 2 month period of time to leave it in the country. And so we firmly changed our plan to never ship anything just because of the ridiculous customs requirement. So we always hand carry everything in duffel bags, and then there's no problem. We divvy it up so we can bring in lots of gear in bags that there's no problem with customs. So conferences are delightful. They're very similar to the conferences I fondly remember as a resident, where the professors are all sitting around, except I don't think anybody wears prayer shawls or scarves like they do here at Harborview or the University of Washington. It's a little more colorful here in Nepal, but the same format. Professors sitting around with the residents and fellows, residents presenting cases, lots of questions being asked and answered, and the teaching sessions are really fun. So I really enjoy these. We do these now when we go every morning before surgery or before the formal lectures. Some more cases. I don't think I need to belabor this. We taught using a 2D camera system rather than the microscope this last time, and you can see Farouk here showing how to use a Vision camera to get this view through a camera-based system instead of a microscope down the metrics tube. We did a whole series of spondylolisthesis with MIS technique. Side visit to a monastery where the group was blessed by a high-ranking lama, and we had a tour of the monastery. Great fun and very, very interesting. And then because of all these efforts, it was pretty clear that just going every year was successful, mutually beneficial to all parties involved. But I thought, let's formalize this. So I founded a not-for-profit 501c3 called the Nepal Spine Foundation in 2021. And it's tax exempt, not-for-profit. And now everything goes through this so that we make sure that everybody's activities comply with the IRS code for tax exemption. So the medical device companies doing their donations are really happy now to donate even more than before because they get a clear-cut tax write-off. And then all the neurosurgeons that join us can work through the foundation in a more official capacity. And we have a board that has people from the US and Nepal on the board, and we have quarterly board meetings. We raise funds through donations, which previously we couldn't do. So we get cash donations from individuals and companies to promote the educational activities. We now have enough money to sponsor the first mini fellowship for either a resident or a fellow level junior faculty, actually, from the Tibetan University Teaching Hospital. So we're going to have our first neurosurgeon come over and spend a month on a mini fellowship between Arizona and Seattle. In other words, my practice and Farouk's practice here in the Puget Sound region, and then Rick Chua's in Tucson. He's at Banner Health, and we're going to fund this neurosurgeon, and he'll stay in our houses and go to surgeries with us. It'll be an observership, so this is kind of a first, and we're very happy to start this. this year, actually it's now last year, but just 3 months ago, we had even the biggest now Maldives conference. Just in contrast, again, building it up even further. We had the vice president of the country give us a talk and pay a lot of attention to what we were doing. This is the conference where we brought the first stealth device in and did the first stealth guided minimally invasive lumbar case. Nepal is getting its first stealth unit this year. I briefly mentioned, and I'll just harp on that because the technology is now able to be brought into these countries way easier than ever before because of the attention that's being brought to the neurosurgery departments in these two locations. So I'm really very proud of my role in helping these places build up their neurosurgery departments to the point where they're now getting and doing very sophisticated cases. The first stealth guided case was, again, a quick side story. We tried to bring a robot in, similar to what we did in Nepal, again, stymied, but this time not by customs, but the fact that the Maldives, which is a Muslim country, found out that the robot was actually built in Israel, and they refused to allow anything from Israel in the Maldives. So in the last moments of the whole process, where we had a Mazor X ready to go, and we were going to do the first robotic cases, that was basically kiboshed. And we switched gears. Thank goodness Medtronic was fabulous to work with, and said, well, we'll get a stealth system for you and you can teach stealth. And that worked out great. And so that's the story there. So when you're doing these types of trips and doing these types of educational experiences, you have to pivot quite often. And it makes it very challenging, but also a lot of fun. This was an MIS stealth guided case that we did. And then similarly, just a couple weeks later, coming back from the Maldives for a few weeks to work here back at home, and then going back to Nepal, we did Spine Week again in Kathmandu. Brought, as I mentioned, 12 folks with me, and we had a very, very busy week. Here are the cases we did in November, which has become the month for Spine Week. And again, in concert with the theme of pivoting with challenges, we can plan the Spine Week dates as much in advance as we would like, but, and this is something, again, I learned from Mohan. He said, but Dr. Wohns, we have to hear from our astrologer as to when our national holidays are being put on the calendar with our Lunar New Year and everything. And we don't know exactly when our big holidays are until closer to, Spine Week. So we have to change the dates quite often according to when their big holidays are scheduled. And it's usually October, November. So again, something I learned, the two big holidays, Diwali and Dashain, are equivalent to our Thanksgiving and Christmas, and you never know when they're going to be. So you have to wait for the astrologer to tell us when we can do Spine Week. So that every year is a challenge, but it makes it fun. Here are the cases. I've left it up long enough. You've probably been able to see what we did this last time. Here's all the people involved in all their lectures. You can see the type of topics we covered. We focused on anterior lumbar this year, and we brought Professor Todd Alleman from Stanford. He did a great job lecturing on anterior and anterior lateral approaches and did several cases. Same with Dr. Matt Neal from the Mayo Clinic in Phoenix. He did some anterior work. And then you can see the rest of us in our lectures We also had a neuromonitoring CEO join us and teach neuromonitoring there. She brought the latest neuromonitoring software and taught up-to-date neuromonitoring, because prior to that, it really wasn't being done according to the standards that we would have here. And then we brought PAs, two from Virginia Mason that work with Farouk, and they talked about what it was like to be a PA helping neurosurgery, because the department in Nepal was getting their first PA this year. So we brought these two wonderful people to teach what it would be like to have a physician assistant and get them ready for getting this new person on board. And then as you can see on the bottom, the Nepal Society of Neurosurgeons had me speak on neurosurgery practice, malpractice update. So on that note, I will say thank you so much for the honor of presenting this little travel log and story of volunteering for now many years, and the development of the Nepal Spine Foundation, the fringe benefit of becoming friends with the Maldivian neurosurgeon who was first in that country and helped build up his program. And Rich, if there's time, I can answer a few questions if there are.
Thank you so much, Rich, for I know you get up at 7. This is not unusual for you, but thank you. This is a fascinating talk. 40 years in the making, really, since you graduated the University of Washington. You've been doing this sort of outreach through Fiends, which was a very admirable organization, is a very admirable organization. So I want to not talk, and I've listened, and I want to know if there are any questions among this illustrious audience. Anything? So someone just speak out. Farouk, you want to speak?
I got a question.
Yeah, go ahead, Pierre.
Yeah, I apologize for interrupting you, Rich.
No, please.
Is there something unique about the patient needs or environment, such as the attitude, that makes you wish you had yet another device that you don't have, or a modification to existing devices?
Yes, always can use more equipment. The stealth system that's coming is something that the government is buying because they recognize the need, and they paid for the stealth system and the cranial software. We were able to get the spinal software donated by Medtronic, and I asked, what else do we need here to make the stealth program work out? And I think to make sure we have funds for continual update on the software is critical, because as you all know, the device is only as good as the software updates, and so that's going to be something that should be funded. But I think what they really need is updated microscopy and updated fluoroscopy. They need a 3D fluoro unit, and right now we use an old 2D fluoro, and we have to basically get it from the urologist, because they have charge of this fluoro unit. And when we do all this spine work, I refuse to do it without having that fluoro unit there full time. I can't have it disappear to the urology suite and then come back and us sitting around waiting. So we have to fight for the fluoro unit. So they really need 1 or 2 more updated fluoro units to be able to do the stealth guided surgeries. We're kind of not thinking of robotics necessarily as being necessary, but since the stealth is coming, to make it really usable, keeping the software updated and having good fluoro would probably be top of my list.
So let me ask you, I'll ask the last question, Rich, because everybody's running to the OR. What is the number one thing that people come to neurosurgeons in Nepal outside of spine? Maybe it is spine, but what's the number one disease or condition state that people are coming to the University Hospital in Nepal for? I mean, you focused on the things, other things, but I'm kind of curious.
Yeah, that's a great question, Rich. And I did focus on what I do there. But I could do a whole other talk about all the other stuff that goes on. And they have a huge number of TBI cases every day. The traumatic brain injury cases are a huge number. So they have a constant influx of all kinds of depressed skull fractures, hematomas, etc. And then there's a lot of aneurysms, there's a lot of AVMs, and the tumors that they get are end-stage tumors, intracranial
natural history. You see the natural history of tumors, right?
Like they don't have 2-centimeter meningiomas, they'll have 10-centimeter meningiomas. They have huge glioblastomas. They have all kinds of skull base lesions. There's massive amount of pathology in the head that they see on an everyday basis. And in general, the theme is that when somebody walks into clinic, they're not just coming in with a little bit of back pain. They come in with major spinal deformities or, the spondylolisthesis cases, which are significant. They don't come in just with minor complaints. They come in with major problems. And if it's an intracranial problem, it's more end stage intracranial problem than we see.
Yeah, that's just fascinating. And I thank you for being here.